Good morning and welcome to our monthly webcast. I am Samir Mehta, your moderator. This is session number 183. We continue with another extremely common, very useful teaching case dealing with calcification, bifurcation, calcification being one particular aspect of coronary interventions which we will make you a master of, something you incorporate in almost 25 to 30% of your case, which exact modality to use, what imaging guidance, and how, of course, to take a stepwise approach. You will master all these with our sessions, and particularly in the case today. The second announcement I need to make this morning is regarding the CME, something which we have been working on extremely compulsively. It is something which has to be done meticulously correct so that the CME organization is supported and we can continue to benefit from it. The plan is to make it extremely easy for you. It will give you 1.5 hours of CME credits by a simple 3 to 5 questions evaluations. I have determined it myself. It takes no more than 30 seconds. The second part of this is answering the 3 questions which Dr. Sharma takes through the end. So that's all there is to it. 1.5 hours of CME, and I think that will help you and of course help the program. With this words, I take you into the cardiac catheterization laboratory where Dr. Sharma and Dr. Kinney are ready with the case. Anu, okay. Samin, good morning. Samin, the message on CME is exact?
Absolutely. So we needed to, this took us a little time to get to this level, but it's about time because there was a lot of need for it. I know it may be less important for out of US people, but it will be useful everywhere. Nowadays, the CME is becoming important for any educational academic center, your appointment and so on and so forth. So our goal is that just by attending, that you will be able to get almost 20 plus CME hours because it's required 40. And then if with the success, then we can extend that to our structural and endovascular if needed. So goal is, yes, CME, because that also increase the level of the our conference and the webcast because you had to have some little more strict rules and regulations, which is always good, and be aligned with the educational theme. So yes, but we'll try to keep it very simple not difficult, and more important, the 3 questions which we'll have, although I give the answer, but we'll just ask people to give those answers back in there, but that will be activated only after completion of the webcast. So, but there will be a link right away, those who want to. Now, only question comes is that we have to decide when the CME need to be done, because it's not for the archived cases. It is only when the live case is going on. Right now, we are only for the live. Later on, we may decide about the archive, but at this time, CME can only be obtained live. So this is a very big message, which we'll send it over e-blast. We'll ask Kim that it is only for the live cases, not for the archive. So those who want to get CME, they have to log in. So that's the only, I would say, limitation at this time, but it will be great. But just to say now, to welcome our team here, myself, Anu, and we are 2 fellows here, Krishna and Swati, of our 8 interventional fellows, and rest of the staff, Will, Alina, our nurses, and CVT, Asif, and Habib, and Kiski, the imaging guru. On the OCT. Today we're going to show the OCT. So I know you want to start the case presentation, which we will do. If you go back to our slide set, the same, the complex disclosures. This is the case number, as you said, 183, 57-year-old male was found with a high calcium score. So this is very important now. And this is what I'll show the guidelines changing also. The screening test nowadays is a CTA. Calcium score or maybe a CT angiography. That's what I tell everybody, not the CTA. I mean, not the calcium score only, but CTA. But if the calcium is more than 1000, they do not do the angiography, but some 256 or 512 slice CT scanner. And now actually the 1100, which is the photon CT, which Mount Sinai will get by year end, that can go even with the 5000 calcium score, can tell us about the CAD. This patient otherwise is fine, no other symptoms, good LV, good control diabetes and hypertension and hyperlipidemia, did have AFib and has been on apixaban, and SAQ score was 77, BMI 29. So we also present all the relevant risk factors, as you saw after a few, since like this is like, since July now, A1C, LDL, CRP, and creatinine. So those are the important ones. Maybe we should add hemoglobin also, because that's important in patient management. Anemia is a big factor. So this patient has a cath who has a
Hemoglobin is 15.
hemoglobin 15. No, I'm saying in our the pre-clinical, the laboratory anomalies, which we are not doing it before July, we start adding it. I would think that hemoglobin will add also, because that's important.
Nurses have been listening to your top 10 lectures, so they have everything ready for you.
Yes. So this case had a 2 vessel disease, although the 3 on the CTA, and by the LED lesion, which we did the rotational atherectomy and DES and did well. All lesions since did not have FFR with the CT. They could not do FFR on the CT, so we did the invasive FFR. Just to say, at this time, the rules are that if you have a CT FFR, you count that as your FFR for your intervention. So you don't have to invasive FFR. Actually, Medicare does not pay the invasive FFR if the CT FFR was done. Other insurances are plus minus. We have seen like about 50% hit rate, that you repeated your FFR even after CTA, but Medicare definitely you do a CT FFR, then you do an invasive FFR, and invasive FFR is not reimbursed by the Medicare. So this patient has a FFR of positive of both, and we did a LED intervention. At that time, syntax score was 22, and now residual syntax score is 12. We did add amlodipine, and now patient is for today OCT guided stage PCI with the multiple calcific lesions of the RA and IVL and plus minus IVL. We are going to show. So this is a 1 vessel disease now. So this will fall into the no proximal LAD, and truly this patient did not have any stress test, but FFR was 0.8 with the 2 anti-anginal, so makes it appropriate. With that note, Anu, you want to show where we are? Go back to the angio now. Yeah.
So this is his old
A very diffusely diseased circ.
But LED stent looks okay.
Yeah.
EF is good. EDP was normal. And this is his right coronary artery.
Look at the entire RCA, calcific, from proximal to distal, bifurcation. The question remains that how much we want to do. In the bifurcation, there is a tight lesion in the AV continuation. As you can see, in a big RPL or moderate size RPL, there is additional lesions in the mid PDA, but calcified all across, and this will be a decision making. So Anu has decided to do OCT today. The question was IVUS versus OCT. Since we'll be talking about both of them, consensus was let's do the OCT because overall imaging being done about 30+% in our ACC and CDR, and 75-80% still IVUS, and OCT is 20%. Many countries is more OCT than IVUS, like India. India is more OCT done than IVUS, but overall the data are like even Renovate Complex PCI, which was done, 75% was IVUS and 25% was OCT. So we actually are about 90-10, but I think with a lot of excitement with the OCT now, probably numbers will start going up on the OCT, because one of the biggest issue is interpretation of the OCT. You need a master understanding by IVUS, everybody can analyze. And secondly, the issue about the contrast use. Definitely, because you have to contrast till we have an agent which will not cause any contrast injection or technique of the OCT will continue to be the issue about the OCT limitation, because creatinine is a very important factor now, and it is one of the Q-hip parameter compared to the door to balloon time. And any time you have a creatinine elevation of more than 0.5, it is NCDR gives you the report card that where you are compared to rest of the country.
Injector.
So with that note, they are trying to do the OCT catheter, not going all the way, right?
No. Can you
So-
decrease
Okay.
the screen?
Yeah, so actually not good clearance.
So very calcific. So I think you have done still part of it, no?
What's
Yeah,
the
good,
reason you
Okay.
think India
one
is
second.
such an outlier with the
Enabling,
use
one
of OCT?
second.
Be ready.
I think it's just probably the
Enabling.
teaching. So
One
so
second.
much.
Please see the index. Yeah, beautiful image. You can take it out.
Your centers bringing the machine. I think it's more how active your program you want to build. But you're right. I think because if you really think about, and particularly the AI programs, and so maybe Anu can answer that AI, OCT has done more in terms of AI implementation compared to IVUS, right? I mean, why OCT should be higher, particularly in India?
No, I think it was just marketing.
Okay, tell us what we found.
Sure, we got the image from the mid part of the RCA. We couldn't close perfectly. So this is start of the mid RCA. Yeah, at least here, eccentric calcium, not vertically inside, it's not nodal, but eccentric calcium. Here, almost like a 270 calcium. And we come to the tightest part. Yeah. Okay, it's true. It's a lot of severe calcium, and the point is
Lovely
very
demonstration
eccentric.
of the calcium. Yeah.
Yeah, because the opposite part is very healthy, no plaque, but the other part is all like calcified lesion. You
And
see
So
very,
it is severe calcium
Yeah,
based
it-
on the length, the
yes.
right arc,
Thank
and
you.
then what's your
Yeah, I will measure. At
Measure.
least here, it 0. Like 1.0, it's more
Wow.
than 0.5.
double?
And longitudinal is anyway more than 5 millimeter. Yeah, and arc is more than 180. It's a calcium score of 4. It's a
And your
severe calcium.
MLD at the tightest lesion?
Yeah, sound good. So now come to the tightest part.
Hmm.
It said lumen is 1.2 average and minimum is 0.9. It's very tight, obstructive. 0.9 is the MLD.
Very tight. Okay,
Yeah.
let's get the rotor ready.
Yeah. So I guess based on this SS, we have to do 1.5
Yep, 1.5, absolutely.
since MLD is.
Excellent images, Kiski. Very.
No, let's make a. What do you want to go to
Question
the?
comes is that how far we need to revascularize this case. So question was that do we just do the proximal or we go distal? But to me, I mean, the question here is, see that very distal also, and then there is a tight in the AV continuum. Patient is young patient. I mean, I would try to do, if possible, go to the distal RCA also.
You mean the bifurcation?
1.5. Yeah. Look at the hair calcified there, and then we have to maybe we can avoid the PDA very angulated in the mid 70%, but definitely the large or medium size RPL AV continuation put a PTC and stent. So question is the distal RCA with the 1.5 bar, and then plus minus of the yeah.
I would just do the proximal SS.
No, but this patient still will be ischemic in that this AV.
no.
Look at the AV. But can
Remember,
you do
it
the
was
AV
not-
without it?
No, just look at the way. So this part, see, heavy calcium in the prox RCA, right?
Yep.
After that, truly speaking, there's no calcium. And then you look at that tortuosity. So with your rotor wire, you'll have so much wire bias. Even when if you do glide, we have to go through it's almost like a normal looking vessel to reach the distal. With this diameter.
Would it be a plausible strategy that after the proximal lesion is done, use the physiology to guide you?
No, it will be severe.
That's a possibility, yeah. So that's another way to answer that question.
I mean, it is significant disease, that's for sure, but very complex.
Yeah. So whole question is, since the complexity is there and it's angiographically the intermediate lesion, can that be just controlled on maximum medical therapy? But your absolutely question where the dichotomy occurs, that if it's FFR positive, then we know medicine alone is not going to work. So that's where the decision will come. But anyway, let's do the proximal.
It will
Let's
be
concentrate
FFR
on the proximal,
positive, yeah.
and then we'll see.
Okay, now give me that, then we'll go with the rotor
Take the other
wire.
wire out. We can take the other wire out, yeah.
Yes.
Samin, going back to the remarks you made regarding the CME,
Yes.
Over the last decade or so, I think the importance of these internationally is almost as much.
Ah, okay.
Now where's the rotowire? Yeah.
You know, a lot of people are, it's a desirable attribute to have, and I think a lot of people will cherish it. I think our big challenge is going to be to transition as effectively for
Can you add them?
the archived cases also, but let's start one small step at a time, get it exactly right. And I think it is helpful for everybody. It makes the program more academic. It helps with the sponsors, and of course, I think it'll even augment our attendance.
No, but where did you put them? Before SS slides start. After the case presentation.
Yeah, but no, so that's a point. I just want to say this will be additional cost for the program, but we are not charging our participants for the CME cost. So we just, but yes, we are, you know, this will be so that, and there is a separate cost for the archived cases. So if we see there's a need for CME for the archive, we'll do that also. But we thought that initially we start with the active live, and then we can go to the second. I'm sure because our biggest audience is the archived. That's where the people go. So this will be selected 1.5 bar because very tight lumen and angulation.
Are you showing our algorithm? Calcium nodule? No.
No.
So, I mean, your use over the last couple of years, I'm sure, is also showing a trend of a single burst strategy, no?
No, that is true. And particularly now, I say in the era of the IVL, if you need to use second device, probably use IVL because that will be less harmful, less complication, less chance of perforation. So by and large, it will be a single burst strategy and supplement with rotatripsy with the approach.
This case looks to be absolutely perfect for that. It's a large vessel, I think.
One comment I have, SS, since I went to ESC, because outside US, a lot of people have an issue because they would rather do only one device because of the reimbursement.
Okay,
So
let's check the speed.
Good.
Check the speed. Yeah. Guide is too much in. Yeah.
Yeah.
Which is okay. See, there is no side hole, sir. So it is.
Okay, let me go.
Now, because of OCT, you don't make the side holes. Otherwise, we always go with the right catheter.
Can you hold the wire? Yeah. I know we picked 1.5 because of two reasons. One, based on the OCT MLD. Angiographically, if we were just going to do the proximal, we could have even gone 1.75.
Yeah. Good. Good. Just keep it there.
Okay. So if you see that, Samir, you see that how the guide is giving us trouble.
Yeah.
So you stay there, and I will, if need, I will need Dynaglide just to do the, maybe just to enter the vessel. But right now we are okay. I'll finish my 3 steps. Tap Dyna, and then let's see the.
Because you're using a 1.5, you are 6 French paste?
No, this is 7 French.
Okay. Just in case if you need to go to.
No, this was more for a bifurcation. If we had to end up in bifurcation of the distal RCA, we thought we go with the 7 French. But you're right. This is by and large could be done with the 6 French.
No, this was more because if you really want to do distal, and we have to use a, Godzilla guideliner to get the rotor down.
Then 7
and
French.
we need 7 French. That was the reason.
Makes complete sense.
Yeah.
I mean, more and more people are moving away from using temporary pacemakers.
Yeah.
And just staying with the aminophylline or...
That is correct. Aminophylline atropine combo, which is okay. But some this kind of particularly you are going through the femoral. I would say the more emphasis, if you are going radial, definitely will not put a femoral pacemaker. But yes, aminophylline and atropine works quite well.
With the proximal.
You want to picture that 160,000?
Yeah.
Yep.
We're done with
Same
what,
155.
where else you want?
At 9 o'clock, there was a disease. Let's see.
Okay.
I'm here. So see this now?
We didn't go with the OCT all the way down
Yeah.
there.
So see the little band? I think we should do that at least use 1.5 bar at 8, 9 o'clock position. Yeah.
5 seconds. 50. 10 seconds. 45. I hope the audience is 20 seconds. Realizing how it is mandated, how in the background you can hear the duration of the bar use.
Have you gone through it, that lesion?
I mean, several questions have come in. Dr. Mahmood Al-Rais, if you could pass a 2.5 balloon, do you prefer to start with IVL or still use Rota?
Yeah. So that's a very good point. So we actually have that algorithm. In this case, although we'll call it a calcific nodule.
Yes, I don't want to go there.
Okay.
And we're coming out because you start seeing some ST elevation and I can sense.
Yeah, massive ST elevation already.
So I'm coming back.
That would be a surprise to have
Give
so
me a
much
run
ST
through
elevation with the
the wire bias could have created some issue at that level. Because if I had pushed more, there would have been a risk of perforation.
At the run
look, by instinct, when you were not going more distally, I think your gut instinct was right. In the meantime, welcome Dr. Sohail Rashid, Samin, a new person joining us from the Bahariya International Hospital in Lahore.
Run through. No, don't give me this.
And thank you for the kind words, Sohail. Hopefully you'll continue to some of our, at the moment, I've got a large international audience. If you can remark, how would these CMEs be helpful to you?
Is probably closed. Okay, good.
Okay, let's go.
This is telling us don't go distally. Look at the STs now. Vessel is okay.
Yeah. We are given a little nipride. I'm giving a little my verapamil. That's my nipride. I love verapamil more than anything else. Although nipride is the nipride. People love nipride. There's nothing wrong in that. Good.
Okay, let us just.
So we are 3-0, 20. 3-0-20.
So I have no doubt that, plaque modification has already occurred, but I would have expected a more improved angiographic result too.
Let's go back because we are more focused because these STs are...
Right.
Okay, come out.
Yeah, so question is why there is so much ST elevations. Look at that. This is only 1.5 bar.
Could be distal embolization.
But with the 1.5, I'm just saying there's such a small bar that we needed that minimum.
Yeah, but you saw the calcium.
Yeah, and Dr. Kini, actually there's also lipid plaque also, combination of
lipid plaque?
lipid and the calcium. Maybe
Yeah, I think that area, go back and show them where there is lipid.
Yep. I mean, some part is like a deep calcium and some lipid plaque on it. So maybe
our goal is to
the lipid plaque and the distal embolization.
3.548.
Yeah, 3.548 synergy.
Balloon dilatation, I think itself will also help. Also welcoming Dr. Gul Zaman Khan from Rawalpindi, Pakistan. Gul and Sohail, welcome to our program. Samin, a question here. What's your view on two-speed rota, Japanese concept?
Yeah.
Our audience is very sophisticated.
Yeah, that is true. So they're actually saying that maybe you do a rota with a low speed, you get a little better lumen, like 100,000 RPM and so. But I think this is our 150 is good enough. Let me open this first. Yeah, 150 is the one which we do. It's quite good. Yeah, 200. The Japanese actually had done the trial. 200 versus 140, and there was no difference. We think 140 was less slow flow. less chest pain and probably less perforation. That's what we know. And I did the experiment back in 1998. Wait 1 second now. Well, let's give vasodilators now.
It's more
1
of
second, no
a
silence. Yeah, and then show that low
kind of a
speed.
theme.
Yeah, orbital. Yeah. So question is that by low speed, maybe you're doing a more of an orbital situation. But
I think you'll have more distal embolization, more chances of burn, entrapment,
wire or
all sorts of
perforation?
issues.
Which one? No, that's always there. Always there.
Okay, a little bit.
No, that's always there. Yeah.
Yeah.
Yeah. Good. So I think we just put the stent first.
3.5.
Yeah.
Right.
48. Yeah. 3.5, 48.
Yep.
Lot of wire bias
Yeah.
at that mid RCA. After that large RV branch, where we stopped.
ST slightly
Just
improved,
slightly
but
better.
still,
Yeah.
It's still there.
very.
I don't think we should do OCT now. Let me stent it and then.
Yeah, no OCT now, no OCT. I have seen in the live cases, they'll try to figure out, we'll do the OCT, you'll see the clear dissection, you clearly slow flow, we do on the OCT or I said, what is going to tell you? Take care of the pathology first, then you do your imaging.
For final optimization.
Yeah, and ultimately what it is, it's the final optimization, which matters. And yeah, there is a questionable, you see thrombus, whether it's a dissection, maybe. But otherwise, when you see clear-cut spiral dissection, decreased flow, diastasis in the wall, you don't need any OCT or IVUS to tell you that it's a dissection. I had a lot of argument of that when I'm moderating the live cases. Yeah, good.
Nice.
Well,
Okay,
you
let
can
me advance
also
a little.
make the situation quite worse.
Yeah, absolutely. That is the whole
I mean,
purpose.
it's not.
Yeah,
It's
take the
not.
rotor out.
No, I have to get this further.
Without its challenges, you know,
Yeah.
you're going to have a dissection. You'll be messing around with imaging.
I think distally I have not reached.
Reached.
Okay, some die.
I'm surprised. It looked to be such a good guide, but
You want to go back with the balloon again?
Yeah,
Because
not
I think
more
distal tip,
balloon. Yes.
we probably never did.
well, also there's significant tortuosity there. I
Yeah.
think there.
And we are not using any guideline or so. Yeah. Take this out.
Okay, get us.
Same
That is
balloon.
a 3.0 balloon.
Yeah.
Now you want to go. You
Yeah.
want to go 3.5?
Balloon? No, we did not cross that lesion. It's a distal AV country, but the mid RCA, we never did the rota, and we had to just go a little further with the balloon, that area. Post dilatation with the 3.530. Post. But let's do this first. So if need to be, we can always use the guideliner. Nothing wrong in that. Godzilla guideliner.
7 French Godzilla ready.
No, but no.
No,
if you're not
if it
planning.
is, so they can
In the
bring it.
meantime, replying to Dr. Gul Zaman Khan, who's asking about the plans for distal RCA. We discussed that towards the beginning, and we'll address that once we make
With all
progress.
this issue in the proximal,
Yeah,
don't even
Probably
think
not
of
mess
going
around.
distal.
Yeah, exactly.
go up.
Exactly right. This is how procedures proceed. This is the importance of stepwise approach, safety always ahead. So, yeah,
A few millimeter back, yeah. Good.
with that
I'm going up.
Go up.
ST elevation and the challenges, no question about chasing. But let's see.
Down.
Yeah, intermediate. I mean, clearly that need to be addressed, but let's take care of the first. Our always was the plan. Do the proximal first, then we evaluate what to be done later. Because we knew the proximal, tortuosity, angulated, severe calcification. So I think that, you know, the calcium is only ACCHA class B. To me, I think they have to give it a new definition of which will be that massive calcification. Remember, like TR used to be mild, 1+, 2+. Now they have massive, torrential. So I think same way.
Remove the vein graft out.
And I think we should put the massive calcification or calcific nodule. That should be type C. So how do you say it? Even by whatever
No,
test,
massive nodule or
more than 0.5
heavy.
millimeter thickness, and the nodule,
Calcium.
so those should be the massive class C. I mean, not B.
I mean, all sorts of thoughts on this. I'm sure you are on the right path, but often while talking about and defining the degree of calcification, we are addressing only the superficial calcification. The question is, does the depth also come into play at some stage? Now that OCT is becoming so sophisticated in demonstrating, I mean, I've become more and more biased towards, I think OCT is a far better comprehensive evaluation of calcification than IVUS.
Well, I mean, the question is quantification, maybe a little interpretation.
No, mainly the depth.
Yeah.
I think
the
depth
of
is
course.
totally lost with the IVUS.
Yes, so clearly that is true because of no shadow after. We can take the rotawire out now. Take it out. Yeah, good.
Now, does the depth matter in the complexity versus depth matter for stent expansion?
Yeah.
Difficult to say.
Right. Very hard.
There's still a lot of ST elevations.
Yes, let go.
But you know, I've
Give me
been
the balloon.
thinking, Anu, more about the depth because of you know, now we have moving into a two device strategy for calcification, and but look, focus on the case first. All this discussion will come later. We've got a challenging case.
When we are presenting this case, and people felt that it's a simple case. I said no. I knew this case will be a tremendous, just because of the degree of calcium, and that is why I think this it's a classical. It's not your regular type B calcification tram track. It's way beyond tram track, thick tram track, which I would say that of course OCTs had almost 1 millimeter thickness, right?
Yes.
1+ millimeter thickness of this calcium, but angiographically to me looked like that also.
So Samin, a very, very excellent question has come in. If you were to use a single plaque modification strategy, what would the approach be?
Rota, period.
Okay.
That's it. This is the case for rotational atherectomy. Nothing else will go. You saw that OCT didn't go.
Also based on the quantification and the quadrant calcification.
It was not going.
Yeah. So I think one device. Now question is, could it be orbital? I think, but only thing is in the tortuous lesions, I'm still a little skeptical. Even using a Viper wire flex, which is a little hydrophilic, should be a little better. But we have seen some cases it doesn't give you support. So orbital, the burr we call crown, does not even cross. So therefore, I'm a little concerned about. So because of tortuosity, the single device here is the rotational atherectomy. You don't need anything else.
Non-compliant balloon followed by IVL.
Yeah. So then question comes: what is the role of IVL after rotational atherectomy? In this particular case, I think what we need to do is we image plus minus, but then non-compliant balloon, and then decide for the IVL. So we'll have our algorithm with the paper which Kiski presented in European Society is under the print, has been accepted, right? Paper and I will share those data next week in our next presentation.
So let me make a proposition here for you, and you tell me where exactly is it wrong. The fact that in case there was also significant, fairly deep medial calcification, almost greater than a millimeter, does that make a difference in your approaching, and would that make you consider IVL in addition to rotatripsy?
Yeah, so the data have shown, our own data, that the IVL caused more plaque crack, the crack of the calcium, fracture of the calcium compared to rota or orbital atherectomy. Right, Kiski, you want to make comment on that?
Yeah, for we did an analysis for the comparison for the calcium nodule treatment, rota versus OA versus IVL. IVL did definitely more frequent calcium fracture compared to the
not crossing,
OA.
short stent, I guess.
So that's a different mechanism.
Good. No.
No,
IVL is
this one further
directly
down.
making a
No,
fracture,
no.
or I'll like shape the
Massive
surface
still,
of the
it will go
calcium
fast.
Yes,
to
yes,
make
give
it
me.
thinner.
Balloon is ready. Yep. So the fracture point of view, definitely the IVL does a better job. Rota will cut the plaque, particularly the interelastic lamina, and therefore, so if the question you said, very thick plaque, is the Rota better or IVL better? I think only thing is that IVL may not get there, so your Rota may be required. In conjunction, the two
Would it-
approaches. But I
would
can
it-
tell you, just to complete, the Rota alone can take care of the thick calcium also. What it'll do, it will just cut part of the calcium, and then your subsequent high pressure balloon or maybe cutting balloon will do the job. Yes.
Go.
Okay. So we are going back again. We need to get a little further down on our.
Okay.
As soon as you're there, you deflate.
Lovely
advance.
demonstration of
Yeah.
getting the guideliner there. I hope people notice that.
Yeah.
I mean,
Give me
it's
the
also
strength.
something which I think you can learn about its appropriate use. Carelessness with using guideliners has caused many complications.
So point is that you always try to advance the guideliner over a balloon. Wire alone, you know that there is a lumen outside, so it can scrape. And if there is a flap, it will take the flap with it and may cause dissection. So therefore, if you have to advance the guideliner after the proximal ostia, maybe a little bit, few millimeter, okay. But then further on, you need to go, you need to go over the balloon. So that is the key. So now
No, not even that. It will not advance.
Yeah.
Okay, ready?
Dr.
I'm going to take this out.
Sinjoy Nandi has asked about cutting balloon after rotablator.
Yeah, so we actually did the Rota cut trial, and basically it showed that it was not did not do this strategy, did not do any advantage, nothing negative, nothing
here,
positive. Go up,
Some
take a little
signal.
picture.
Okay.
Yeah, messy ST elevation still. Good.
Good. Okay, go.
Yeah. So key is the Rota cut concept is good. There are some data of this cutting balloon, although, COFS trial, but that was just not with the Rota. Only cutting balloon, they went into 22, 24 atmosphere. So that did show a little better in the calcific lesion, better lumen compared to a non-compliant balloon. But overall, Rota cut strategy, to me, enlarging the lumen in the cases when you have done the Rota, whether you use a cutting balloon or IVL, to me, I think if
high pressure balloons.
Yeah, you go non-compliant high pressure balloon, that doesn't work, then you just go with the IVL. And as you know, by next year, there will be 4 other companies which will come with the IVL catheter. They're working one with the lasers, there are 2 others soon. There's a device called Fracture. Trial will be starting, which is the laser guided IVL. Then there are other balloon-based IVL. So many things are coming, this IVL field. But right now, I think we'll take probably towards end of the next year to have the final results of those, any other device in the market. So now let's take
Another question, Samin. Can you use a 1-to-5 burr through a 5 French guide extension?
Yeah, so
No.
let me put it this way. You cannot use the 1.25. We have tried it. They actually write it in their product that you can use it. But practically, we have done multiple times. You cannot use 1.25. You need a 6 French.
No, you say a guide extension.
Yeah, guide extension, I'm saying. Guide extension.
7
You need a 7 French guide
7
extension.
French,
Yeah.
and you need guide extension 7 French to get a 1-to-5 bar.
Yeah, exactly.
That was the reason. I remember in the beginning when we asked why did we use 7 French was if at all we knew we wanted to go distally, it could have been a 1-to-5 burr, and for that if we needed guide extension then
I know mild haziness in the very proximal part.
yeah, it's a dissection, we have to cover it.
Okay.
Okay, get us a 3-5-12.
But let's do the dilatation for the first balloon.
No, let's just put the stent there. Huh?
No, but that's in the end.
Okay.
And 3.512.
Why did you?
Synergy also. This is we don't need. So now, and question I always say, these guideliners and so, take them out when you don't need them, because they always will decrease the lumen and will decrease the flow. See that just by tracing is good, STs are down because of establishing the flow. So I can tell you once again, let me emphasize, the people say, there is a chart going on and which I had refuted that 1.25 bar you can put through the 6 French Gardella, which is 5.5 French, and answer that is maybe you can succeed once. They say you front load is this and that, all 100 different strategies, but no, it does not go. If you have to do it just like we were supposed to do here, they use a 7 French Gardella, and then only you can put a 1.25 and 1.5 actually, both of them.
Down.
Yeah, H.
And this is the case which we said, if possible, this is the case you need a the pacemaker. Now, we didn't need a pacemaker here, but we wanted to do more vasodilatation. This is the case who can develop AV dissociation and so. So this is type of case I will try, not relying only on atropine and aminophylline, that we go with the pacemaker.
Having a pacemaker is like having an impella in LV dysfunction, where
In
you
this
can,
case.
yeah.
Because
you see that if this patient really had a slow flow and we consistently had to give verapamil, other all vasodilators, hypotension, all this, then you definitely need a pacemaker.
Absolutely, and I hope that our viewers are able to appreciate that, and I'm a witness to this for more than 20 years. I mean, nobody has more experience in using the rotablator than you. So that inherently may be a very good strategy. After all, I mean, there are potential issues regarding, but it takes 30 seconds to put in a pacer wire there, and can save you in a few cases a ton of grief.
Question also is that why we still have ST elevation. We have a distal diffuse disease many times. All this debris that we have created has no outflow, though the flow is very good. That could also be a reason we have this persistent STs.
I thought slightly it may be related to the guide too. I'm not convinced. A couple of times when you were, I was noticing when the guide.
Everything is coming out here.
That's okay. Atropine. I mean, give some more verapamil. But see, the STs are, it's all flow mediated. So not surprised that this much debris came, originated in this particular case.
Going back to Kiski's observation that there was some lipid there also, which probably in addition to the calcium.
No, I mean, rota should not touch the lipid. The mechanism is that it should not touch the lipid compared to orbital, where we know it orbits around the vessel. What we have seen is when you're doing just PTCA, right? When you're just doing PTCA.
It's not only the rotablator you used, other
balloon also.
Yeah,
no, but we saw slow flow after rotational atherectomy, more so, some die.
So no, I mean, this is the lipid and no lipid. Remember that still, by and large, the mechanism in this patient slow flow is all that calcium. Even if there was no lipid, this was expected. Only question was, since our OCT did not cross, and I'm telling you now that since OCT did not cross, should we have used 1.25 bar? I'm telling you one little more bold statement. Ready?
No, 1.25 would not have done much.
No, that's different. Then you can go to second. I'm going up.
Go.
Just because the OCT did not cross. That's because of that. Otherwise, no. Otherwise, we don't do that. Let's go a little forward.
I mean, we also teach when you see tram track calcium, you don't have to do imaging, just go directly with the burr.
Yeah. Let's go
this
further.
is one thing that we saw. You saw, it was not easy to get the OCT catheter across the proximal lesion.
Yeah.
And if there is no good distal flow.
Overlapping. I want to go a little further.
You should not even do the OCT. There's a risk of VFib.
Yeah. Just 1 second. Let me go more negative. Good. Good. That's it. That's all we need. Yeah.
Okay, ready for the OCT?
Overlapping segment.
Should we do it with STs?
No, will be STs are good now.
So, Samin,
I
the
won't say it's
question
good.
is for delayed flow, do you prefer nitroprusside or adenosine?
All three. No, we don't have adenosine. We are not that fan of adenosine. Nitride, verapamil, and nitroglycerin.
Yeah.
Not so nitroglycerin, but I think nitride
Importance-
probably is a better off. But if some
importance for-
people feel adenosine, because I know some attendings even here in our lab, they like adenosine. But I think between adenosine and nitride, one of the.
Yeah. So adenosine is more steady, as you know, in an acute MI setting, slow flow of the acute MI with
Thrombotic, yeah.
Amistad trials and so. But very little data on the rotablation arena. So your guide
Ready?
has to come
Importance
out.
is that
No, it's okay. It's all
nitroglycerin has
segmented.
no role.
Yeah, that's it.
Which one?
Nitroglycerin, yeah. Only for epicardial spasm.
Ready.
Good. Ready?
So another question is, would you consider adrenaline?
Yeah. In refractory cases, yes. The only question comes down to that in refractory cases, we had to, if you can give, you take 1 cc of epi. So best is, look, adrenaline taking is different. Take 1 cc of that epi of 1 in 10,000 dilution, 1 cc dilute in 10, and then you give only 1 cc, half of 1 cc. It will cause a tremendous tachycardia, may cause a lot of PVCs. There are some cases that you can have little VTAC, but just give 1 cc of that dilution. And for refractory slow flow, intracoronary refractory slow flow will help. Now, you can always give intravenous, will increase the blood pressure, which is completely fine. But intracoronary, if you need to give it, I would say intracoronary of 0.1 cc of 1 to 10,000 dilution of epi.
The dose for anaphylaxis, not
Yeah.
the dose for ACLS.
That's it.
Samin, a few people now want you to answer this and address the decision about the distal.
Yeah.
And
So
I
I
can
think-
see why
No,
they are
let's
saying
ask.
because
Let's put in the chat what they would do. Then we will say what we would recommend. They can
Well,
answer in the chat, right?
just from
No, but we
the-
have not seen the distal picture yet because we have
No,
to
we
do
are- we
more
are.
vasodilation
No,
in epicranial picture. Yeah.
No, you've seen
We
it.
saw that.
in the
Yeah.
last view,
Yeah.
I think they were watching right
Yeah.
there
Yeah.
and making the observation. And I
Yeah.
think it's a good observation because that lesion does look
More.
more now.
Yeah,
I
agreed.
think part of it may have been some embolization there too,
Yeah.
or slightly because of the wire maybe also, but
Yeah.
it is looking maybe does need a epicranial view with
Yeah.
nitroglycerin.
Yeah. I can tell you that I want to do a full revascularization young patient. If need to be, I would not go with the distal RCA today, the way this patient has behaved. Let it recover, and I would do the functional test. Stress
you.
nuclear that time, we decide because circ also very diffusely disease.
Right.
So then bring back for the third stage, RCA plus minus circumflex.
Nice. 1 second.
Okay, go.
Enabling 1 second.
Because this guy going to release some leakage.
Calibrating. 1 second. Yeah, please cine inject. Yeah, beautiful image.
Take the wire out. Everything.
No, we may have to post the proximal.
No.
Foro.
Very good, very good.
Second.
And in between, I would say we should get his LDL less than 55. Sorry, LDL is less than 55. His HDL is 29.
9. Yeah. That
We got to
cannot
work
take
on
care.
that, which I know we do not say or talk to the patients. We got to
image.
tell them that to exercise.
Yeah.
Yes. Okay. So yeah, I should
Look at the STs. See? Almost near normal. Can we increase the... Oh, sorry. First, let's talk about the OCT findings first.
Sure.
Then we go to the hemodynamics.
So actually, the distal edge has slight, like an intimal dissection, very small dissection, but the stent is well expanded through the vessel. And actually, the MSA is 5.7. It's optimal. And our proximal edge is also, it looks great, like a slight malapposition.
Yeah, see?
Yeah.
I said that.
Foro.
Got to post
Then
it.
take a foro.
Yeah, distal edge has
No.
slight dissection.
No, that's exactly. Okay, go back and teach them that what are the criteria because they do not meet the criteria of another stenting.
Yeah, so most important is the minimum stent area, and now it said that it's automatically generated 5.7 through the vessel. If it's more than 4.5, it's more optimal result.
No, are you at the distal edge?
Yeah, distal part of the stent. Yeah, this part, this part is 5.7.
Okay.
Proximal area is like more than 7, 8, huge, well expanded.
And where is the mala position?
Go back there.
Yeah, so this is just a proximal edge, like
Yeah.
here, but it's on the branch, so we cannot
I think
perfectly oppose here.
No, is this the branch or what is the distance? It should be the one. Is the one stud thickness?
So this is a branch, so we cannot perfectly oppose here. Like here, this is the end of the stent. This is the wall, and with the branch.
Yeah.
We can leave that. Go back to the distal edge,
Sure.
and we don't need to place another stent so that we can teach the audience why. Look at that.
This cross section is exactly distal edge of the stent.
Okay.
And a little bit go distally. Yeah, here like intimal, like a flap, very small, less than 60 degree, and not come to the medial, just the intimal like injure. But longitudinal
and the arc is
arc is less, flap arc is less than 60 degree.
Yes.
So
and the length.
Length is also 1 second. So here.
So you got to get the arc, the length. The length is barely 2, right?
Yep. Maybe less than 2. Yeah. I think it's true. More than 2.
I think 2 criteria don't meet. It hasn't reached the media. Just a little bit intimal flap.
It's a minor.
So leave it alone.
Minor is dissection.
Yeah.
Good. Okay. Now let's go back to very good. Now let's go to the hemodynamic tracing, please, on the main screen.
Anu, would it
bring it the screen above, hemodynamic, make it large. Look at that. Patient good, no ST elevation, patient having no chest pain, we found out. Look at that.
Perfect. Completely baseline.
Wow. Okay, now I'm taking the last picture, and then we'll go to our, the second.
Low mag.
Yeah, no, bigger mag right now.
I'm taking away all the things.
Excellent. I think
Can do low. Yeah.
completely
Right?
done there.
So, yeah, moderate, but I would not say, discard the possibility that we may have to do it distally. But I will now, in about 2 months, we'll do a stress nuclear test, and based on the inferior and lateral ischemia, we bring it back for part 2, part 3 actually, in this case.
No, you were asking me a question.
Yeah, often we have seen you put in a balloon distally at low pressure to augment the flow and patch up the light, the little intimal disruption. Would you consider it here, or
No?
Based on the results from OCT, you're happy to leave it?
Based on the results of the OCT, I'm happy to leave it. I'm not a fan of touching any part of the vessel that does not need our.
So that is called a Sharma Colombo massage.
Yeah, it's
We both of do. Colombo does it and I do it. Our same balloon, go distally, leave it at 2 atmosphere for about 30 seconds and take it out. Colombo does it and I do it.
Just to let you know, both of you, the last 5 consecutive questions in the last 60 seconds have talked about this particular point. Should you leave the distal edge alone? So I'm glad you answered it. Dr. Kinney would completely leave it alone. Dr. Sharma may put a balloon there at extremely low pressure, but either way, the patient is doing fine. Excellent result. Samin, please proceed with your didactic.
No, what I was trying to teach is, since now imaging guided is becoming, he will show all the guideline changes. People have to know, okay, we are doing imaging. What is that we are understanding from imaging? The final verdict is stent optimization and the best result of the stents, and that is what we are talking. When you are seeing something, when you know you met those parameters, and when you see, because it is like you will see some other things like this, especially dissection, when what to do for the dissection. That's why we went through the criteria of the dissection. So should something be done, and can it be left alone? So this can be left alone even based on imaging criteria.
Right.
So completely agree. Anu, before you leave, a very important question, several questions questions have come towards the antithrombotic.
No, I'm not leaving. I am coming back because we are showing.
Know that a pioneer AFib could be Xarelto if it was 15 milligram with the clopidogrel, but since it already was on apixaban when I did the intervention of the LED, what we do is we give aspirin on the day 1 and no more aspirin. Although recommendation still says sometimes that you can give in high risk cases aspirin for 1 month, but we don't give it. The apixaban or Xarelto, the rivaroxaban 15 milligram, apixaban 2.5 or 5 based on the renal function and age, twice a day, followed by clopidogrel. Very rarely we'll use the strong PTY12 with those will increase bleeding, but sometimes we do. Like in this particular case now, he has no bleeding risk. He's a low, otherwise low risk for bleeding. It will not be, and he had the slow flow. I would say I would not be, against adverse from using the Procedural 5 milligram. Because we saw that how much plaque burden and things he has. So nothing wrong in that. Although they did the PRU, we actually have the team ready. What is the PRU? 113. So PRU very active. So those cases, since we have already done the testing, I think we can leave it alone. But my gut feeling in this case would be what you do when you're already on clopidogrel, you load with 30 milligram of Procedural, not more, and then 5 milligram daily.
It was not. It's not about this case. Yes. Huh?
Okay.
No,
so Dr. Kini wanted to say something, and then we'll go to a presentation. Yeah.
No, this was just a CalcificAID. I wanted to see how we would have done this case with the app. This is the updated CalcificAID which we released recently, where we go through how we can do, device synergy.
Okay, perfect. So let's go to our CalcificAID algorithm. This is the updated CalcificAID. So you had to tell them.
This is our case? No. Oh.
Yeah, we did last one.
Okay.
Was very good one. Yeah. Okay. Let's go to our Octave. Go to our presentation. And there also will require a lot of imaging gurus give some opinion.
Any other questions you said?
Huh?
No, you said there were a lot of questions came.
No, about the distal dissection. 5 questions in last 30 seconds. Yeah. If we can go our slide presentation, this we have done.
But are they okay that with our answers?
Yes, completely happy, completely satisfied now.
So today will be the day of European Society of Cardiology. Anu was there, Dr. Roxana Mehran. I invited her, but she could not because she has some other commitment. And Kiski, a lot of presentation by Mount Sinai team. So we had a high flag, Sinai flag in ESC, and it was in London. So I'm going to talk about 5 of these trials. REC-CAGEFREE, one trial, OCCUPI trial, which is OCT, GUIDE-DES with IVUS, then SCOFI trial, which is my heart, which is that feed the patient while coming to the cath lab, and the resistance, microvascular resistance. Then some update on the European guideline. You know that we are very slow. America is very slow in comes up with their guidelines, but European already came every year. Every year they come with some focused guideline and otherwise a full change. So they came with the full change of the guideline for the chronic coronary syndrome. And there's, which is our stable ischemic heart disease, which we used to call. And then it's again different. Europe calls those stable angina as a chronic coronary syndrome, which makes sense. Why? Because you have acute coronary syndrome. But America is again different. America call it chronic coronary disease. I don't know why. But same thing, the TAVI and TAVR. So that plan always continues. To me, chronic coronary syndrome is a better terminology. Let's go to the first one. First one is the patients, as we know, at present, the drug-coated balloon are a lot of advertisement, a lot of data coming. The drug-coated balloon are good things. So there are some data from China, actually, many of them for multivessel disease, besides for ISR, which have been shown, which led to the AGED trial approval in United States, but very expensive device, $5,600 cost. Reimbursement is 0 at present. But when they are trying to see what could be the new technology pass-through code, what will be the cost, we don't know. Till that time, use of drug-coated balloon will continue to be very small. In America, we are in 2 drug-coated balloon trials. We have done the solution ISR study, already completed. Now for the small vessel VR. So this was all comers, but simple lesions. considering the concept of the drug-coated balloon, if fails, you put a rescue stenting versus go with the DES. This is called the cage-free 1 trial. So basically, this was done in China. A non-complex lesion were 1 or 2 lesion, length less than 60, no bifurcation, no left main, no CT or no grafts, and no need for atherectomy. And large number of patients, about 1100 plus. Now they use a special drug-coated balloon. This is not our classical the drug-coated balloon. Sequent or agent or the others, Swide paclitaxel coated drug-coated balloon, although they have shown the data that is comparable to Sequent, other published the drug-coated balloon. And then they have the stent is the Firebird 2 sirolimus eluting DES, again made in China, both these products made in China, and Firebird has been compared other stents in the past, but that was the plan. Either use the drug-coated balloon, if fails, the 9-point rescue stenting in 9%, or you go with the drug-eluting stent. So that was the concept in the simple lesion. And guess what we found? And look at that. Device-oriented composite endpoint, cardiovascular death, and TLR, both were superior, means better in cases with the drug-eluting stent. So means much lower, almost half. Individual points are here. So this event rate went in half, 6.4 to 3.4. Your death actually 3.3 to 2. P-value of 0.06, so important, which we saw. There's no difference in stent thrombosis. TLR, of course, was significantly lower. And lastly, the bleeding. Only thing was that bleeding was slightly the DCB group was lower because probably maintenance on the longer antiplatelet therapy. So just to say, this was a shocking data presented because this concept so far has not shown in any trial. In the earlier trials did show some of the drug-coated balloon that in the RIFS trial and so showed that the drug-coated balloon was better than the DES was better than DCB in ISR cases of the bare metal or drug-eluting, but then some trials showed good because they have the whole dose release like 3 microgram per millimeter square of paclitaxel or sirolimus, and this field is ongoing, but this has put a real dampen on this enthusiasm of the drug-coated concept. And you take individual endpoints, a majority of them, they are actually better for the drug-eluting stent. And if we put it together, then we say, well, maybe a small vessel will do better with the drug-coated balloon. It was identical, no difference. In the non-small vessel, large vessel, there was a 3 times higher event rate. 7.5 versus 2.5. And their authors rightly have a nice conclusion that this study indicate that DES should remain the preferred treatment for this patient population. So therefore, this is the whole the saga changed what we have been taught in last couple of years about the increasing success of the drug-coated balloons. Then the IVUS trial, the OCCUPI trial basically is investigator-initiated multi-center randomized trial from South Korea in complex coronary lesion. This is again now the 6th trial in last 2 years. Or the imaging, actually 6th or 7th, and basically to randomization to the OCT versus IVUS, OCT versus angiographic guided, basically, and overall 1,600 patient. And very interesting, they went to the optimization strategy. So 3 things which we talk about: edge dissection, stent expansion, and stent apposition. When people ask, these are the data. So in clearly that if your dissection means your flap is less than 60 degree and less than 3 millimeter, and there's no deep vessel injury. Our case had no deep vessel injury. It was 2 millimeter, and what was the flap circumference? Less than 60 degree. So that is cause those small one can be left alone. Now let's go to the stent expansion. For this trial, although many of them are same, that more than 80% of MSA of the mean reference or distal segment 100%, or lumen of more than 4.5. And the lastly, maximum distance between the strut valve, which the apposition is less than 400 micron or less than 200 micron. So basically 2 strut thickness difference, and those are they achieved optimization in 71% of cases and sub-optimization in 29%. Why I'm putting a little extra time? So maybe knowing that the KISKI is quite much involved and we are trying to do more OCT. How do you comment on these criteria? Are a little unusual or very tough to achieve? What do you think, KISKI?
To the previous, like a big trial, like Illumine 4, a little bit complex trial. So, and I think the big difference compared to the Illumine 4 trial and this one is the patient enrollment. But because this patient is all complex PCI, but the Illumine 4 trial is also included complex patient, like 40% is just DM. But I think this is the answer for complex lesion. OCT can do better clinical outcome compared to the angiographic guided PCI.
Beautiful. So that basically was, these are complex lesion, acute MI, CTO, lesion length more than 28 millimeter, calcification, bifurcation, unprotected left main, small vessel. I was a little surprised calling a small vessel. Isn't that there is a cutoff less than 2.5 millimeter vessel? We don't use OCT. Is that not true? Anu?
We do that. We have put the thing because even here, if you pay attention in the early part, there was not a lot of dye. There was dye stasis when I did my first OCT. I would be very careful in doing small vessel, and large vessels you don't see anyway because you need more dye. I know this is criteria. They said 2.5, they could do it. Myself, KISKI, we were discussing how we can do OCT in 2.5 vessel with disease.
Yeah. So 2.5, or I would say the less than 2.5 or more than 4.5 are not good cases for OCT. But they did in the trial, but that's okay. So what they found, OCT guided decreased the event rate by 30-40%. Individual you can see there, although there was no difference in stent thrombosis, some of the trial have shown, and there was no other, interesting also, there was no difference in CIN. Exactly remain the same, and so what they basically found, that once you do angiographic guided, your primary, which we call target lesion failure, was 7%, went down to 5%. Clearly, as you can see, significant reduction by 38%. From 7 to 5, then within that 5%, they actually had that optimization or sub-optimization. Remember, 71% has a full optimization and 29% as sub-optimization. There was a big gradient, 3% versus 9%, 3 times higher. So clearly, you have sub-optimization of your event rate increased 3 times. If you're suboptimal OCT, your event rate was even a little higher than angiographic guided. So what Anu pointed out, that not only you have to go that do the imaging, but you have to react to it. Where it is suboptimal, it's better not to do it and just do the angiogram. So that's a very important lesson we learned from this study. So basically that these findings indicate the existence of a therapeutic benefit of OCT as an intravascular imaging technique for PCI guidance in patients with complex coronary lesions. Then there is the third trial, also comparing, same, on the imaging point of view, what if you do a QCA? QCA, although many of the programs are available, online QCA, as soon as you do angiogram, you can do the vessel length, vessel size, the degree of stenosis. So QCA, could it be as good as IVUS? And this is a very good point. And now again, the study done in Korea, the GUIDE-DES, and these are the patients, large number of patients randomized to QCA guided PCI versus IVUS guided. And QCA basically, as soon as you took the picture, guide fill catheter, and online, right away you calculated the vessel length, vessel size, lesion, and so on and so forth. And they found that by QCA guidance of your balloon, and stent, identical outcome at 1 year, 3.8 event rate, and individual endpoints are there. So the QCA coming up as the good as I was. Same thing like you remember the QFR. So that FFR, but angiographic FFR. So those also has become equal. So this is one of the, but this one, they say because of the lower than expected target lesion event. So this may not be really understandable. The other one is, I would say, which I have been propagating or popularizing for last probably decades, that you don't need to be fasting for procedure. So people used to say, nurse will call me, oh, patient just had a lunch 1 hour ago. I said, make sure, call the patient and give cookies on the way down. I always was, they know it. I said, no fasting needed. There have been few small trial. Another very big trial, as you can see, SCOFI, this was done from Australia, and the fasting versus no fasting, 3 hours. They still have a 3 to 4 hour fasting. To me, is like 3 or 4 hours is way too long. So what they did, the majority of these patients were angiogram. It's a 83% has a PCI, 83 angiogram and 17% EP procedure. In the angiogram, there was a 30% had a PCI. So only 30% of patients PCI, and they were found basically is that fasting versus non-fasting, the event rate were much higher in the fasting patients, and those are aspiration, pneumonia, low blood pressure, high blood sugar. That event rates were lower. Primary composite outcome, hypotension, hyperglycemia, and showing here the fasting event rate 19.1, no fasting 12, less hypotension, less hyperglycemia, aspiration, pneumonia. So all this thing was people worry about that aspiration, but no, because current dyes do not cause nausea, vomiting. That started with the ionic dyes where it used to be so much. But fasting here was 3 hours still. From my point of view, there is no need for fasting at all. So here they have at least 3 hours of fasting, but should be none. So this is what I would say, that more and more data have shown, because biggest, I would say, satisfier, patient satisfier is that they have eaten, they are not waiting empty stomach. Now, if you are doing anesthesia, that's a different story. They want a strict 8-hour fast. If by mistake our patient with the tower has eaten at 8 o'clock, they will not take that patient in the room before 4. So this is not applied to that patient. So, but routine procedure, EP procedure, which will not require intubation, and patient with our intervention, no fasting needed, although they had 2.54 hours and so. Then another just quick factor is the microvascular resistance reserve, measured immediately after PCI, Australia, Belgium, Japan, and USA. Basically, they went the CFR, thermodilution divided by FFR, multiplied by PA at rest and hyperemia, and they came up with the point of the microvascular resistance reserve, which are less than 0.25 or more than 0.25. More than 0.25 is better, and correlated with MACE, all-cause death, and spontaneous MI as shown here. Very interesting. Look at the death difference. In MMR of more than 2.5, mortality was less than 1% versus 3.4 if it was less than 2.5. So this is the resistance reserve, and of course other endpoints are shown here. So therefore, whether one trial will make any difference, because these patients have a lower MI. Those who have a high MRR, and these are the individual endpoints and shown here, and the combination of IMR, which is the less than 25, and more than MRR more than 2.5, they all showed a very good result. And so key is another measure we have in patient's prognosis, that your MRR should be more than 0.25. And this is actually a nice editorial talking about the microvascular resistance. So let's go to the next one quickly. That is the updated guideline of the 2024 of European Society for Chronic Coronary Syndrome, and with the cardiothoracic surgery, presentation of chronic coronary syndrome, asymptomatic patient or patient with chest pain or patient who have MI or acute coronary syndrome in the past, but now have stabilized, and MI, they actually first time went through beyond just the epicardial, structural, functional, or microvasculature, which happened with the microvasculature, just like resistance index, which was shown in the previous slide. And recommendations, and important recommendation basically came that now coronary CTA in many categories as a class 1 indication, as a screening test. So one good thing, CTA, and then of course then you do if your CTA coronaries are okay, CFR and microvasculature you count it as a 2A or 2B indication. But if you are taking the patient after CTA, like our case, you need to do FFR and IFR. That is what become QFR, and FFR, IFR, all the class 1 indications. So patient, based on the CTA, unless the CT FFR has been done, you need to do those FFR and QFR, which we did in our case. And then of course the patient with a high risk. So this basically has come up that a patient with a CCTA as a first line treatment, and invasive evaluation if patient is the high risk for CAD. Very interesting. Patient who is very high risk for CAD, you go for direct cath. Symptom despite guideline directed medical therapy, low workload, high suspected CAD more than 85%. You don't need to do all those fancy tests. Otherwise, CT has come as a very important test for the screening these patients. So few of the things important I want to say, people always ask how much exercise we do. They actually have a good guideline. Aerobic physical activity, at least 150 to 300 minutes per week of the moderate intensity, or 75 to 150 minutes per week of the vigorous intensity and reduction sedentary activity. So key is that's class 1. And of course, multi-disciplinary behavior approach to help patient lifestyle, pharmacological management, mental health, and all those. But key is the exercise. You need to do about 300 minutes of exercise per week, which will translate into about a 1 hour per day for 5 days. Then the second point was in complex cases, same way that you have the heart team discussion and then make a decision what to do for those particular patients and so. And low ejection fraction, they have given more important that those patients should go for surgery. Very, very important, which I super highlighted. First time in our guidelines, the intracoronary imaging with the trials of last 10 years. Everyone positive have made to the European guideline. We are not the American guideline yet. That intracoronary imaging guidance by IVUS or OCT is recommended for performing PCI on anatomically complex lesions, in particular left main stem, true bifurcation, and long lesions. So based on our trial, IVS, XPL, the October trial, and the left main PARC data, all have made it that class 1 indication now for those complex cases, whether it will be in simple cases, need to be seen. And then also, very important that ultimately is the physician. We can give the recommendation to the patient, but look at the patient's preference. It is recommended that physicians select the most appropriate revascularization modality based on the patient profile, coronary anatomy, procedural factors, ejection fraction, and patient preference and outcome expectations. So patient still remain the final decision maker. We can say that you're going to die more with this procedure, that procedure, but patient ultimately has to decide what is the approach. And we have published that almost 50% of the patient, despite we recommend go for PCI, for CABG, they decline and come back for PCI. So then the left main disease basically is a nice, particularly that while most of the cases, the left main is a class 1, but patient with a syntax score of less than 22, in whom PCI can provide equivalent completeness of revascularization as of CABG, PCI is recommended as an alternative to CABG given its lower invasive and non-inferior survival. So now finally, another point, the left main made to the guideline with a syntax score of 22 or below. But you know that in the Excel trial it was 32, but since there was some question about higher mortality at 5 years, so the authors were here, I would say rightly so, keeping it for the low syntax score patient. Higher syntax score still remain the same, but more importantly also that if you have intermediate severity, that is a 2A, in whom PCI can provide equivalent completeness of revascularization as of CABG, PCI should be considered given its lower invasiveness and non-inferior survival. So they made that as a 2A indication. So very, very important. And then of course, patient with high surgical risk, patient can be considered over medical therapy is a 2B. So a lot of changes, and I think these are very important guidelines for us. And then the DES, patients who have revascularization failure, DES is recommended, or drug-coated balloon for treatment of DES restenosis. Very important. Although American guidelines may change that because they approve the agent, and agent is against balloon angioplasty only, was not against the second DES. That was the big the drawback of the agent trial. So what our guidelines will be, we need to see. But until now, the guidelines for 2A, American guidelines, the drug-coated balloon can be used for ISR. They do have still DS as a one, where it will be, we need to see. Also, on the right side, that if patients have normal coronaries, angiographic normal or have ischemia, that you go for the appropriate, particularly the functional testing, and direct their therapy for refractory angina, and they do make it also to be as a sinus reducer stent. These are individual, many of them, and then more important for the antithrombotic, antiplatelet therapy point of view, that once you use NOACs, you use only antiplatelet therapy, single, and then withdrawal of the aspirin 1 to 3 months in patients who are not high ischemic risk. So this is where, and then of course in the bleeding patient, you can cut down the whole, everything within 3 months and start the single therapy. Also, a lot of emphasis on the 5 dimensions of adherence in the disease, healthcare provider, patient, therapy, and healthcare system. So same, the patient has been discharged. There should be a follow-up mechanism. Make sure you are given a statin, but have you checked what your LDL is? LDL still remain 90, is no good. You need to go down to 55. So all these are important. They have made it. So let's just complete our presentation quickly. The European Society, drug-coated balloon plus rescue stenting versus DES for native CAD, thumbs down. OCT guided versus angio guided PCI in complex lesion, 2 thumbs up. QCA guided versus IVUS guided PCI, no difference because low event rate. Doesn't matter why you want to do any additional because IVUS will tell you many other good things. Then no NPO versus fasting pre-cath PCI, thumbs up. And then prognostic value of the MRR after PCI in stable CAD because of mortality is a 2 thumbs up. Then the 2024 European guidelines, Society guidelines for management of chronic syndrome have shown many new recommendations. CT as a screening for moderate to high CAD likelihood, direct intracoronary angiography for high risk of CAD and symptoms at a low workload, avoid routine stress testing post PCI, short DAPT with aspirin withdrawal after 1 to 3 months, intracoronary imaging as a class 1 in complex left main and long lesions, PCI class 1 for low syntax score left main CAD, multivessel disease assessment in ANOCA and ANOCA cases, and emphasis on aggressive post-PCI adherence on care and healthy exercise well-being. So with that note, we start with our 3 questions. Following statement is false regarding the results of REC-CAGEFREE 1 trial comparing drug-coated balloon plus rescue stenting versus DES, similar POCE, trend towards higher death rate, similar MI, similar stent thrombosis, and higher TLRA. It's not similar device or patient oriented because event rate were higher in the DCB group compared to the DES group. Second, following statement is false regarding the results of OCCUPI trial comparing OCT versus angio-guided PCI in complex lesions, lower MACE rate after OCT, lower TVR rate after OCT, similar MACE rates between the stent sub-optimization group and angio group, then similar stent thrombosis after OCT versus angio-guided PCI, and lastly, lower MACE rates in stent optimization versus sub-optimization group. So basically, in this particular case, C, similar MACE rates between the stent sub-optimization group and angio group is the true statement. So this way, because MACE rates were identical
False.
for the sub-optimization group and angio group, so this should be the true statement because everything else is correct.
So this is false.
Yeah, so we have to just change it, the question on the top. So basically that was a wrong question. So basically if you have sub-optimization stent, the similar in the OCT, your data are similar to angio. The last one, following statements are true regarding the various class level indication for left main revascularization except PCI is class 1 for syntax score 21, CABG is class 1 for syntax score 33, CABG is class 1 over medical therapy in all syntax score to improve survival. PCI, if can be done well with complete revascularization syntax score of 23 to 32, is class 1, similar to CABG. And lastly, in high surgical risk patient, PCI is class 2B over medical therapy alone. So question is, which one statements are true except? So except basically means the D, that even if you can do complete revascularization in the intermediate syntax score, it's not class 1, it's a class 2B, 2A. So therefore, the D is the wrong answer. So this basically is conclude our 3 questions for this, and we concluded today's presentation.
Samin, your excellent and such a comprehensive review has made our session remarkable today. Excellent case plus so many. I mean, we could spend an entire session talking about the exuberance of the drug-eluting drug-coated balloon. There was already a signal in the peripheral study from 2 years ago that, hold on, maybe you're trying to go for too much, maybe it was a safer strategy in stent restenosis, maybe small diffuse disease in diabetics, but going in and comparing with the DS, I think was a long shot, considering also, I mean, this is not something which is a $5,600. They were trying to, I think, go for too much. I think Kiski must be particularly delighted with the ESC because he had grumbled to me that, this should be class 1 indication. Yeah, and I am sure it's people like him who have worked so hard And there is absolutely no doubt that this is a step in the right direction. So Kiski, congratulations. Now, I think the resounding message I got from your fantastic presentation today is that ACC, AHA, and SCAI needs to get their act together.
Absolutely.
We have fallen terribly behind. The fact that the Europeans have gone ahead and made a seismic change, 1A class for left main for PCI less than syntax score of 22 is something which affects so many of your patients. I think 10% of your patients fall in that group. Yep. And many other incredible including the 1A classification for imaging, which I think was clearly needed. I leave you all with the message that Grubhub should be delighted. Now they can put a cath lab of Mount Sinai for their meal delivery. With that, we conclude today's session. Anu, congratulations. Beautifully done case. Kiski, thank you for constantly teaching us more about imaging. Samin, great case overall. We'll see you on October 15th for the next session.
Thank you.